Good evening, everyone. Uh, Respected Dr. Lakshmi Narasimhan sir, President of Indian Academy of Neurology. Respected Dr. U. Meenakshi Sundaram sir, Secretary of Indian Academy of Neurology. Respected Dr. Kothari sir, who is the President-elect as well as founding member of this Neuro-Otology subsection of Indian Academy of Neurology. uh, Dr. Rohiwal sir, who is a senior neurologist from India, and Dr. Srinivas UM, who is a convener, who is my colleague and friend, who is a convener of neurology subsection, our distinguished speakers and respected colleagues and dear friends. So it is my great pleasure to welcome you all for today's academic webinar organized by Indian Academy of Neurology under the heading of Neurotology subsection. So today's topic is advances in vestibular rehabilitation, which is a very important and rapidly evolving area in the management of patients with all the vestibular disorders like BPPV, vestibulopathies, functional vestibular disorders, and various other vestibular disorders. Vestibular rehabilitation has moved far beyond a simple, set of exercises, and today it is structured, individualized, uh, outcome driven, functional deficit driven, not just diagnosis driven. And it requires proper clinical reasoning, understanding of vestibular physiology, careful assessment of the deficits, identification of various components like postural, visual, movement induced components, and recognition of most important is psychological factors as well, and then tailoring the therapy to the patient's specific needs. So under the neurology subsection of Indian Academy of Neurology, we have been conducting these monthly webinars, and I'm really thankful to all the participants for excellent response we are receiving. And this participation shows the growing interest in this field of vestibular medicine, and it also tells that there is a strong need for continuous academic exchange, skill development, and collaborative work and learning. So I would also like to take this opportunity to appeal all the attendees to join the neurotology subsection so that you can receive regular updates, participate in academic activities, contribute to discussions, become a part of growing group dedicated to advancing and understanding and the vestibular disorders. So today we are very fortunate to have two excellent talks. The first talk will be by Dr. Helena Esmond from Philadelphia, USA, on approach to vestibular rehab and complex cases of BPPV. And the second talk will be by Dr. Sheetal Naik from Dubai on case-based vestibular rehabilitation, diagnosis to recovery. So the format of today's webinar will be like Dr. Helena will speak for first 30 minutes, followed by 30-minute talk by Dr. Sheetal Naik. We will then have a Q&A session until 8:30 p.m. Indian time. And I request the participants to kindly post their questions in the chat box during the talk, and they will be taken up during the Q&A session. With this brief overview, I once again welcome you, all of you. Thank you for joining us this evening. It is now my privilege to introduce our first speaker, that is Dr. Helena Esmond. So, Dr. Helena Esmond is a vestibular physiotherapist from Philadelphia, USA, with extensive experience in vestibular rehabilitation, BPPV, vestibular migraine, triple PD, concussion, visual vertigo, and complex dizziness disorders. She is also the co-founder of Vestibular First and has been actively involved in vestibular education, uh, clinical teaching, journal clubs, academic programs for vestibular clinicians. Her profile reflects a strong combination of clinical expertise, teaching, innovation, and commitment to improving vestibular care. Her topic today is approach to vestibular rehab and complex cases of BPPV. Now, without further delay, I invite Dr. Helena Esmond to begin her talk. Over to you, Dr. Helena.
Thank you, Dr. Puar. Very appreciate your introduction, and I'm so happy and honored to be here and to share ideas and information. I'm going to share my screen so that we can begin the talk, and we'll discuss vestibular rehabilitation. So, I first want to acknowledge that throughout the world and including and very much so in India, I see so much wonderful research coming out, and I just want to express my appreciation. I view one of my jobs as a vestibular clinician is to share information. So we're sharing information with our patients so they can better understand why they're feeling the way they are and to try to help them feel better whenever possible. And then we share information with each other so that we don't feel so unsure about how to help our next patient. We have more support and resources. And I know that I myself feel very called to share the research and help other clinicians know what research is coming out. So I do quite a bit of that, as Dr. Poir mentioned, as far as journal clubs and things. And so if you're doing research, please feel free to reach out to me. I'll have my email at the end here of the talk so that I can put up a social media post about your research or perhaps have you as a guest. It's really my joy and pleasure to do anything I can to share all your good work for those who are out there. So I thank you. I think you all know the vestibular system, I hope, is our inner ear balance system. It's kind of this little tiny sensor in our inner ear embedded in the temporal bone. And we know that that input has to be integrated with our vision and our joint position sense. And that integrator is the brain, our very, very important captain and computer that tries to put all this information together so that we have a sense of balance and so that our gaze, our eyes can work together as a team to keep things from being blurry or double when we move our head, things like that. So in a way, when you put it on this slide, you say, oh, that doesn't seem like so hard. I think all these things can work. But unfortunately, if any part of this system, or sometimes multiple parts, unfortunately, has a problem, whether that's our inner ear balance sensor, that vestibular system, or our vision, or our proprioception, and or that brain can get, unfortunately, having some sort of disorder, whether that's a tumor or a stroke or what we call functional issues, which is more the software of the brain, kind of helps everything connect and work together as a team and process the information effectively. If those parts have a problem, then the patient can experience various symptoms, dizziness, imbalance, nausea, off feeling. There's a laundry list of symptoms. I no doubt you've heard your patients report. And this is one of the challenges is that the type of symptom the quality of the symptom generally does not seem to help us with diagnosis, according to the research. So we do rely upon our physical exam, what technologies we have available to us, listening for what we call diagnostic criteria for various conditions that you might be familiar with. This is where we try to be the detective to help our patients. And so when we think about vestibular rehabilitation, well, this is like, okay, we figured out the diagnosis, I hope, hopefully, um, and hopefully we have it right. And now what are we going to do? So vestibular rehabilitation in general is an exercise approach to reduce dizziness and imbalance associated with our peripheral or inner ear balance issues and or brain issues, which would be the central vestibular dysfunction. So you see I have an example chart of only some of the problems that can happen with the brain that can result in dizziness. So these are our central vestibular diagnoses, most common being vestibular migraine. So perhaps you've had talks on that, I hope, because it's unfortunately one of the more common diagnoses. So we want to make sure we can recognize it. And then there's no real test for it. It really does require ruling other issues out and then looking at diagnostic criteria. And so then we go down the line with these other issues, and then you say, well, how can vestibular rehab help all of these problems? And it is a good question. So we know that with the vestibular system, what we're looking for is first, if there's a medical problem like a tumor, it will be difficult to get the patient feeling a lot better if we can't address the tumor. So sometimes that might involve surgery or radiation. The patient has vestibular migraine. Sometimes there's medical management, different medications can be tried. So I do like to say, particularly for the brain, when the brain is the source of the problem, anytime there is a medical management piece, we must not ignore it. So I look to my physicians here in the US, they're kind of the leaders on that end of things. And I might be the first to suggest a certain diagnosis, and that's okay. I see this as a team approach. So as a physiotherapist, my job is more that rehabilitation side. But certain conditions, if we don't get the medical management in place, it'll be difficult for vestibular rehabilitation to help. So I kind of need that to be a part of the picture if possible. So this is where the communication, at least here, that is how it is typically done, is kind of communicating to say, all right, what are you going to do your part of things? Okay, you're going to tweak this medication for migraine. Okay, I'm going to, then be able to progress the therapies, because otherwise it might be difficult for the brain to learn and change if it doesn't have some medical support for certain conditions. So for each of these conditions, it's kind of depends on the condition. Like sometimes it's very much a structural issue, like Chiari malformation. It would be very difficult for vestibular rehabilitation to help if that's not medically managed to the extent that it can be, right? And then we'll do the rest we can with try to make brain changes, help the brain to learn how to do balance as best it can, even if that problem is there. I call that work with what you got. So sometimes there are structural issues we can't change, and then we do vestibular rehabilitation to try to, optimize what nerve cells are there that are good. Not every nerve cell has damage if there's a tumor or a lesion or an issue. So we kind of work with that. But that's a kind of a team approach that I hope is happening around the world to try to address the vestibular rehabilitation piece, because I don't want to see clinicians who are trying to do vestibular rehab get set up for failure. They're like, oh, I'm going to do this care, and there's no medical management of the medical piece if it's possible. And again, sometimes there's no medical management. It's simply what we can do in rehabilitation to optimize our outcomes. So just want to kind of touch on that. And then here in this chart, you'll see I've summarized kind of some of the rehabilitation strategies. So for all of my patients, even if they have a peripheral issue, honestly, I do educate them on lifestyle. So this is kind of the truth that blood flow is key. So we want to be doing some kind of exercise whenever possible. Um, there are various options for that. I even have patients who are so symptomatic, we have to start with lying down exercises. That's still blood flow to the brain. We need blood flow. This is good. So we want to try to optimize that aspect, as well as considerations like nutrition, hydration, stress management, things like that. So it's super, super important with vestibular migraine, but it is actually really important across all diagnoses. And then anytime we have findings on our exam as a physiotherapist, like a balance problem, or I have certain balance tests I can do, then we can try to train balance. And if they have a neck issue, it might not be the primary cause of dizziness, but many people who are dizzy start to kind of walk around really stiffly. So we might want to give them neck care as part of our physical therapy plan. And then there's, of course, kind of the formal vestibular rehab exercises, which I'll show you a couple of examples of shortly. One is called different names, eye and head coordination, or eye and head, active eye and head exercise, or two target exercise. I'll show you that one. That's a really wonderful exercise for many issues, those many different vestibular issues that are due to brain problems. I find it particularly useful for that group because it is slower and a little more gentle. Whereas gaze stabilization, which might be familiar to you as like a faster head movement, I'll show you a video with that. That's really the most helpful in people with peripheral issues, peripheral vestibular damage. But sometimes it's appropriate for brain issues as well. So that's where you kind of have that as be more advanced exercise for someone who has brain issues that are causing dizziness. And then we have this kind of concept of habituation, which is kind of gentle exposure to movements that cause some symptom, and try to help the brain to learn to process that movement better. And there's some certain strategies for cueing that I'll teach you or to talk about today. So here's the example of that two target exercise, just to kind of give you a sense. We're going to watch this video. This person is looking at Post-it notes that have letters on them, maybe A and B, and they're going to look with their eyes and then their head from one letter to the other. So you move your eyes first and your head second. Now you're going to say, boy, that person's going really fast. Well, on social media, you have to have every video be super short, like maybe 30 seconds at most. So in real life, these movements are a lot slower. So I might have the patient move their head, okay, move their eyes, then their head. So it's much slower to start. And then if they get good at it and it doesn't bother them and they don't feeling that dizzy, then we can increase the speed to something more like what you're seeing in the video. And this can be done horizontally between two targets, vertically between targets, diagonally. So you can see that in these videos, she starts with two targets and then it progresses to multiple targets. So there's a lot of ways to work these vestibular rehab exercises. And the other thing that's characteristic of this video is some patterns in the background. And so we can, perhaps have a piece of cardboard that we put some wrapping paper on that has a pattern to it, something like that. Some patients are what we call visually sensitive. So they're sensitive to visual patterns. Some people call this visual vertigo. Something in the vestibular world is everything seems to have lots of names. But anyway, so when people are visually sensitive, we might want to try to decrease that sensitivity in some cases. So there's the option to do patterns like this or even video patterns. Lots of videos online. Gabriel Pierce is a physical therapist who put up a ton of videos with like driving or walking through a busy store, things like that. So we can use those videos as a background, put our targets on top, really train the patient to be focusing on the targets and ignore the busyness behind. They're trying to reteach their brain to filter or to ignore unnecessary visual information. So that gives you a sense of one vestibular exercise you might give a patient. Here's another example. So this kind of falls into that category of gentle habituation or kind of repeated movement. So we're going to have this patient working on going up and down, which is a common direction of movement where people tend to be sensitive. So they'll say, oh, when I bend down, I get dizzy, or when I come up, I get dizzy. So that might be appropriate to train. So here we have a patient who's, again, the video is accelerated, so we would normally not do it this fast, I promise. But they're finding playing cards with certain numbers and then number circles on the floor, and they're tapping them to match. And then they're adding other elements like walking and then bending down and coming up. So you just kind of can gradually progress the patient over the course of a session or perhaps several weeks. It depends on how they're tolerating the activity. So a lot of options with gentle repeated movements of different types that can be progressed to faster or bigger movements as the patient can. And here's a balance activity example. Lots of options in the vestibular rehab world for balance training. So this one's using uneven surfaces. Those little hard pieces are called river stones. And then we have the round ones, which are called balance pods. And then you have the blue squares that are kind of a foam pad. So lots of different ways to create uneven surface. She's having to tap her foot to different spots so that she has to kind of stabilize her balance. This is a more advanced activity for sure, but just to give you an idea of a progression, something a little more challenging. And then she's adding a cognitive challenge, something to focus your attention on. And that's tapping a color that's called out by the therapist, things like that. So we can really increase the dual task or multitask. And the reason that's important is because the literature is consistent that various vestibular issues, whether they're in the brain or in the peripheral system, take away resources because the brain is busy trying to keep you balanced and do extra work to help with that. And so it's harder to maybe focus on a secondary task like, looking at your list at the grocery store and finding the objects in the store you need or what have you. So very good to work on some multitask or dual task with our different vestibular rehab and balance activities. And then, of course, function. So we like to make it customized to the patient whenever possible. So what do they have to do in their daily life? What are they interested in? What do they enjoy? This can help the patient enjoy the rehab better so that they want to participate more and do their home exercises more often. And it also can help them really be safe and have less symptoms in the environments and activities that they'll be doing on a regular basis in a way. So we try to replicate that in clinic whenever we can, as much as we can. So this video has an example of someone who was going to return to going fishing. And so you can see there's some different activities that are really vestibular rehab activities. This is two targets, and she's looking between two targets while she's walking. And then we have some uneven surface balance work. She's following a target with her eyes sometimes. That's called VOR cancellation or suppression, and that's another way to work on decreasing sensitivity to visual motion. And then we have practicing functional activities like picking up something while I'm keeping balance on the uneven surface or carrying my fishing pole. And then here she is returning to her activity. So, um, we try to kind of get creative in the clinic and try to figure out how can I help this patient with this goal, whether that's returning to a sport or being able to put dishes away in a cupboard that's overhead. And so we practice different functional activities in a gradual way as well. So I want to give you a couple tips that any clinician, whether you're doing vestibular rehab or you're a physician who's referring to vestibular rehab, but you have a patient in front of you that's saying, "Oh my gosh, every time I turn, from left to right as I'm standing, I feel dizzy, or every time I sit up from lying down, I feel dizzy." So you might be familiar with this technique. So it's just for anybody who maybe hasn't heard of it, is using our eyes as a way to help reduce dizziness if we have vision. So we're going to fix our eyes on an object in the environment as we move. And ballerinas do this as a way to improve their alignment. And so if I was going to turn from left to right, instead of just turning my head and letting my eyes pass over everything in the environment, I will switch my eyes from the fire extinguisher to the doorknob to the electrical outlet that's in front of me. So I'm really switching my eyes from object to object in the environment as I move or bend or turn, instead of just letting my eyes pass over everything as I move. So it's a tip that you can give your patients if they're experiencing dizziness with certain body positions or movements. The long term would be get formal vestibular rehab and to get appropriate treatment, like say they have BPV, and that's why they're feeling dizzy when they bend down. Then we want to treat that root cause. But this is a strategy to kind of act as what I call a bridge. How can we reduce symptoms in the moment with a functional activity? All right. And then another option or idea is during vestibular rehabilitation or even daily movements, we try not to let the symptoms ramp up and stay very, very elevated. The danger of allowing symptoms to ramp up is that sometimes the brain will then essentially learn that dizziness is normal, or that's kind of how we're going to be now. And so this is sometimes characterized as persistent postural perceptual dizziness. Um, it is kind of a learned dizziness, it's a functional dizziness. And so, unfortunately, many patients who have different vestibular conditions or even medical events, such as a heart attack or a huge stressful event, will start to kind of learn to be dizzy. Like their brain will just kind of have a pattern of, oh, my daily life equals dizziness. So they'll have fairly constant or really, really strong um, consistency of their symptoms. Like they'll feel dizzy most of the time, most days. And that's kind of a tip off. They might be developing persistent postural perceptual dizziness potentially. And then we also want to look for eventually, if it lasts more than 3 months, there's criteria for 3PD or persistent postural perceptual dizziness. So we're trying to not let that happen. But even if it's already happened, anytime we're in vestibular rehab, I don't want my patients to experience, if 0 is no dizziness and 10 is the worst ever. I don't want them to be at a 10 out of 10 if we can avoid it. So if they come in to me and they say, yeah, I'm about a 3 out of 10, mild dizziness, and we do a vestibular rehab activity, I don't want the dizziness to be more than a 5 out of 10. So we might do, bending down, coming up 3 times in a row. How do you feel? Oh, just a little bit more dizzy, maybe a 3.5 or a 4. Okay, we can do another round of that then. So we're really pacing the rehab. It's not just, okay, spin around a bunch of times and feel as bad as you can, and then let's see if you feel better eventually. That's not how the brain usually learns not to be dizzy with movement. So we want to kind of follow this 2-unit rule for symptom increase. And every once in a while, we have patients who have a delayed onset of elevated symptoms, and that's a little trickier to treat. But we want to try to kind of learn that then and then kind of really modulate the inputs as best we can to avoid overloading the brain and then kind of having it be in a high elevated dizziness state that just lasts for hours. So if we elevate those dizziness symptoms a little bit, that's fine. And then if we elevate it, hopefully they'll settle down within a few minutes. And so we can do ideally another activity once they've settled back to baseline. Another thing to consider is what might limit a patient. So they're going to vestibular rehab and they're just not getting better. So the number one question I always have is this the right diagnosis? Are we treating the right thing? So if we think someone has BPV and we're doing a bunch of maneuvers, 3, 4 in a session, and we're seeing this patient several sessions in a row, and there's really no change in their symptoms or their presentation, I'm doubting my diagnosis of BPV. Maybe I mistook vestibular migraine for BPV or something like that. So we want to kind of do a really good reassessment at that juncture. And then we also want to look at other possible barriers to progress. So one of the possible barriers is using vestibular suppressants. So that'd be medications such as meclizine. I think beta histine might be one. Anything that would suppress the vestibular system, we want to avoid. Whereas Zofran, which is something that you could use to like settle down nausea, that's not a vestibular suppressant usually. If someone has a BPV issue or a vestibular peripheral damage issue, and then they also have migraine, that's going to be harder to treat because we're asking the brain to help and the brain can't help as much. So any brain issues, we want to treat those as best as possible to help the vestibular rehab go better. And then we want to look at vision. Are they using multifocal glasses, which can kind of confuse the brain? Maybe we want to get kind of set those aside during our vestibular rehab exercises if we can. And like I mentioned, shooting the neck, doing our home exercises, sleep. If a person is not getting good sleep, it's going to be really hard for them to get better with exercise or vestibular rehab in general. So we want to address those sleep issues if they need sleep care or education on sleep hygiene, things like that. If they have autonomic nervous system issues like dysautonomia, some POTS, which is a kind of a certain kind of dysautonomia, anything like that, that might be impeding our ability to progress with vestibular rehab. So treat that if it's present. Getting the patient moving in a gentle way as best we can, because we know that sedentary lifestyle will decrease the effectiveness of vestibular rehab. And then if they have emotional challenges, they feel sad, depressed, anxious, and that might be pre-existing before the vestibular condition, or maybe it develops since the vestibular condition. But if it's present, we want to treat those issues because with this proper psychiatric support, because otherwise those could be barriers to progress in vestibular rehab as well. All right. So let's talk about, we talked about brain. Let's talk about the peripheral system. I've kind of alluded to it already. So these are, hopefully you're familiar with these common vestibular issues in the inner ear affecting the vestibular nerve or other structures in the inner ear, the vestibular system. And that issue can lead to a lesion either on one side or sometimes on both. So we know that there's a sudden onset, say like a neuritis. Sometimes the brain helps in part on its own. It doesn't, need vestibular rehab in the beginning necessarily. Like that first day or two, the brain's trying to really do its own thing to try to recalibrate. And that can do an okay job. But at a certain point, it's going to plateau. And we find that usually that plateau is not where we want to be. So then we have something called adaptation, which is where vestibular rehabilitation comes in to try to train the brain to recalibrate to maximize the ability to use the available information from our inner ear sensors. And then there's compensation, which is going to rely upon the brain to learn new strategies to bypass loss function. And this is particularly common in bilateral vestibular opathy because you have less to work with on the information side from the inner ear. So here is an example. I hope you've seen this. Someone having an impaired peripheral vestibular system on both sides. One way we might see that would be an impaired head impulse or head thrust test. This patient has impairments on both sides. And so we talk about what's called a compensatory saccade, a little eye jump. So you're going to see that during the test, but we actually use that as a treatment tool in a way by using our two target activity, for example, to help the brain just get really good to making little eye jumps to fill in for the fact that the reflex isn't working properly. So that would be a compensation example. So here's our patient getting their head impulse test. This is not a treatment, this is a test, but it lets you see what a compensatory saccade would look like, particularly when the patient's head is thrust to the patient's left, but you can see it to the right as well. So we're going to use that type of strategy, which you can see on the test, to our example in rehab as well. And we also are going to recognize that there is real research on the benefits of vestibular rehabilitation. So we find, for example, that at least 3/4 of patients, 75% or more, with unilateral vestibular hypofunction or vestibulopathy as an example, will experience improved balance, reduced dizziness, and increased quality of life with proper vestibular rehab. And they have also found that a greater number of therapy visits, that doesn't mean they need to go for 10 years or anything, but it's not just 1 or 2 visits. Usually you're going to need a few weeks to really see improvement. 4 to 6 weeks is in the literature, for example, to improve gait speed, which is a balance measure. And I mentioned doing neck care before. Here's a little more specific information about stretching and strengthening and really providing good neck care actually maximizes or even increases the benefits of vestibular rehab more than if you just do vestibular rehab by itself. So some of you might be familiar with what I consider to be early vestibular rehabilitation strategies that are still used to this day, such as the Cawthorne-Cooksey exercises. And there's research to suggest that they can be beneficial. However, eye movements by themselves without head movement, that portion of the exercises don't seem to be as beneficial in general. We really need to get the head movement to get the brain to really calibrate properly in both central and peripheral issues. So here's an example of gaze stabilization, which is a mainstay of rehabilitation for unilateral and bilateral vestibulopathy, as long as the bilateral loss is not complete. So there's still some residual function left, which often there is. I'm going to play this video. So Danielle Tolman is an excellent vestibular rehabilitation therapist in the US out of Georgia, and she just gave us a nice visual example of that VOR times 1 or vestibular ocular reflex exercise for gaze stability. So it's a fast head movement, it's a small head movement. You can do horizontal as well as vertical. And you know, if the target, the letter on the post-it note, or words on the post-it note are blurring or doubling, you want to slow down the head movement a bit, which she demonstrated, so that we can try to optimize the input. We want to have it not so much that it's super blurry, but not so slow that we're not kicking on the speed necessary to get the brain to really try to recalibrate. So this is best for our peripheral vestibular issues. We want to make sure this is a part of our care plan for them. So here is a beautiful summary chart of the recent clinical practice guidelines that were developed for rehabilitation for unilateral and bilateral vestibular hypofunction or vestibulopathy. And there's both acute and chronic unilateral information as well, depending on how long the patient's had the issue. People with chronic or greater than 3 months unilateral vestibulopathy can still benefit greatly from vestibular rehab, so we do recommend that. And there's lots of other information here. Feel free to check out more resources at the Academy of Neurologic Physical Therapy. There's a lot of free information. You do not have to be a member to access most of this information, so that's great. So yeah, that is a tool, and you can put that in your toolbox for your own clinic, or if you have someone you're referring to, you can pass it along. So I want to spend a couple minutes on atypical BPV to finish. I kind of heard a little too late that you had a recent talk on this already, so I apologize for any repeat information. But I just figured I'd just cover this topic very briefly because we do run into it in the clinic as well as part of our work as vestibular rehabilitation specialists. So, you know, BPV is kind of a mechanical problem, little otoconia or calcium carbonate crystals that are supposed to be in the middle part of our vestibular apparatus, the utricle, make their way into one of the 3 semicircular canals. There's the explanation of the abbreviation for BPV for you in case you're not familiar, which most of you probably are. And so we want to know the anatomy if we're going to know what's happening. So these little otoconia can go into various parts of the canal. They can go into what's called the short arm. They can go in what's called the long arm. And you see those with arrows demonstrating where those different regions are on either side of the cupula, which is our membrane, at the end of each canal in the large part of the canal called the ampulla. And then there's that section that has a common area between the anterior and posterior canal called the common crus. So very good to know that anatomy. For testing for BPV, of course, we can use our Dix-Hallpike test, which you see demonstrated here. And there's a loaded version that you may or may not be familiar with. That's really nice to use, where you kind of turn the head towards the side you're going to test and tuck that chin down for 30 degrees excuse me, 30 degrees for about 30 seconds prior to bringing them into the Dix-Hall pike. And that's going to increase your sensitivity by about 13%. So really nice thing to add for those kind of difficult cases or atypical cases. Now, if someone comes in and they're super symptomatic, you probably don't need to load the test, but otherwise I find it really helpful. Um, Other ways to optimize your testing so you don't miss BPPV that was there, but you just thought it wasn't because you didn't get nystagmus, you didn't really get symptoms. You can use infrared video goggles, and then you can retest the Dix-Hall pike one additional time on each side if the first testing round shows no nystagmus. And there's some nice literature that suggests that you'll catch cases that you would have missed otherwise just by doing one additional retest. Types of BPV might be familiar. There's either floating or stuck. Fancy terms for those are canal lithiasis or cupula lithiasis. And of course, the direction of the nystagmus helps us know where the otoconia are. So here's an example of otoconia in that short arm, which is one of the atypical forms we see. And for that patient, we're going to see a downbeat nystagmus most likely. And then there's also a possibility of otoconia being in what we call the non-ampullary segment of the long arm, which could also create a downbeat nystagmus. So I'm not good enough to tell if it's in the short arm or the non-ampullary segment, except by the response to treatment. I think they're working on trying to figuring out if there's some subtleties to torsion and things that might help us with that, but that's beyond what I can do. So I just try to try a treatment and see how it goes and go from there. So here's just a quick example of a downbeat nystagmus you might see in someone with short arm posterior canal beat V. Sorry, it's a little bit small, but you can see that little tiny small eye movement. And one of the most challenging things about a downbeat nystagmus is there's lots of downbeat nystagmus that's not from BBPV, but rather from a brain issue. And we're going to talk about that in just a minute so you don't mix up those cases. And you're probably aware of that from other talks as well if you've been to the other talks. Here's a nice clue that someone has a short arm posterior canal BV. They have an upbeat when they come to sitting sometimes. So up torsional beat or upbeat might be a clue, especially if it's short duration and a bit symptomatic. So that's another tip for you. And then we have, again, these central mimics. So the brain might have a problem and it might look like it's BPPV in our positional tests. So unfortunately, that's quite a bit of dominant nystagmus is from the brain and not from BPV. And of course, we can't forget our horizontal canal. And you probably know the work from Dr. Badari and her group, which shows that horizontal canal is much more common than previously thought. And here's a nice algorithm that I have more detail on my website, vestibularfirst.com, for free if you want to check that out on horizontal canal testing. And know that vestibular migraine heavily mimics in horizontal cases, so just watch for that. And the main thing I want to emphasize is that if there's a brain issue, BPPV, it's going to have a latency or a kind of a little bit of delay before you get the nystagmus, and that's less likely with brain issues for positional nystagmus. And also the nystagmus was more likely to fatigue with repeat testing when it's BPV, and it usually stays about the same every time you test when it's central. Nystagmus also usually lacks torsion when it's central. And most importantly, nystagmus won't change with maneuvers if it's from the brain. So that's really rare. So as BPV, you're more likely to see a change with a good maneuver. And people often ask me how many maneuvers should it take to clear BPV. Here's a nice grid for you as a reminder. So we're not doing, 17 maneuvers. That's really not necessary or appropriate. And the good chance is you don't have BPV if it takes more than 5. All right, so here's just a treatment summary for BPPV. I want to let you know we have a bunch of free handouts that you can print out if you'd like on different BPV maneuvers. So there's a link there for you. And you can go to our vestibularfirst.com and find that link as well. And we also have free videos of many BPV maneuvers, and those are available on our YouTube channel for Vestibular First, if that helps you. And I just want to show you my favorite maneuver. If you don't know which side's affected and you're not sure if the otoconia are stuck or floating, it's called the square wave for horizontal canal. So you can check that out. And then for the atypical posterior canal BP, there's lots of choices. Modified Jacobino, Basfule. If you need tips on vibration tools, I've got two of my favorites listed here. And then there's other maneuvers for short arm, but I'm going to skip over those because I know we're short on time. I just want to end by saying that if a patient has BPV treatment and they feel dizzy, even though you know the BV is cleared, there is benefit to vestibular rehab after that as well. And there's also recommendations to not give the patient vestibular suppressants and to ensure they have adequate vitamin D and other medical support for the risk factors for recurrence. So there's my information. If you want to reach out to me with any questions, please feel free. Happy to help.
Yeah. Thank you very much, Dr. Helena, for that excellent and very practical talk. And you have beautifully highlighted, the approach to vestibular rehab as well as how to approach complex cases of BPPV. And your session was has given us a structured way to assess patients with vestibular disorders. Thank you once again for sharing your experience and insights with us. And we will keep the questions for the Q&A session at the end. Now, it is my pleasure to introduce our second speaker, Dr. Sheetal Naik. So, Dr. Sheetal Naik is a vestibular physiotherapist at Tarabishi Vertigo and Balance Center, Dubai. She has 16 years of clinical physiotherapy experience across Dubai and Mumbai, India, and she has been actively involved in vestibular rehabilitation for patients with vertigo, 3PD, visually induced dizziness, vestibulopathies, MDDS, and balance disorders. Her clinical work focuses on evidence-based rehabilitation, balance retraining, functional recovery, patient education, and individualized therapy planning. And I'm also proud to introduce as she is an important part of our vestibular and balance rehabilitation team at Tarabishi Vertigo and Balance Center, Dubai. So it is privileged to see her structured and patient-centered rehabilitation approach, which has helped many patients with dizziness, vertigo, and complex vestibular disorders regaining their confidence and improve their balance in daily life. So today she will be talking on case-based vestibular rehabilitation, diagnosis to recovery. Her talk will focus on practical clinical cases and how vestibular rehabilitation can be planned, progressed from diagnosis to functional recovery. So I warmly welcome Dr. Sheetal Naik and invite her to begin her talk. Over to you, Dr. Sheetal.
Yes.
You can begin. Your screen is visible.
It is visible?
Yeah.
Just a minute. Thing. So good evening, everyone. Thank you, Dr. Vishal, for that kind introduction. I'd like to begin by sincerely thanking the Indian Association of Neurology, subsection of Neuro Otology, for this wonderful opportunity to present today. It is truly an honor. I would also like to express my heartfelt gratitude to Dr. Vishal Pawar for this mentorship, his guidance, and above all, for believing in me throughout the preparation of this work. My name is Sheetal Naik, vestibular physiotherapist at Tarabishi Vertigo and Balance Center, Dubai. So today I will be taking you through a case-based approach to vestibular rehabilitation. I hope by the end of this presentation, you walk away not just with new clinical knowledge, but with a different way of thinking about every dizzy patient that walks through your door. So before moving into the cases, I would like to briefly outline the structure of today's presentation. I will begin with a short introduction discussing the steps on how we approach patients clinically and developing treatment strategies based on the outcomes. And then I will be presenting a series of interesting cases. So, the introduction. So, the goal is no longer just symptom control, it is functional recovery. Effective rehabilitation begins with identifying the true functional impairment so that we can tailor our rehabilitation accordingly. Now, before we dive into the cases, this is our clinical approach that we undertake at our clinic. So it starts with a detailed history and examination because the patient's story often contains the diagnosis. That leads us to vestibular testing, which is objective, structured, and comprehensive. So our testing battery covers the full spectrum of vestibular function. So we have video nystagmography, which helps with assessing the eye movement nystagmus analysis. We have SVV to assess otolith, mainly utricular function integrity. We have caloric testing, which assesses canal-specific hypofunction by measuring eye movement, responses to temperature-induced inner ear stimulation. We have video head impulse testing, which tests the high-frequency function of all semicircular canals. Then we have postrography, which helps in assessing balance and sensory integration. We have functional head impulse testing to assess functional visual stability during head movements. We have rotary chair testing to assess bilateral vestibular function. We have vibrator testing to assess neck proprioception and to provide stimulation to the otolith organs. We have craniocorpography to assess body sway and postural deviation. And then we have WEM to assess the utricular and saccular pathway integrity. So the results then allow us to map the functional deficits, whether it is a canal pathology, visual dependence, vestibular hypofunction, sensory mismatch. And finally, all of that feeds into a truly individualized rehabilitation plan. And every tool in our rehabilitation arsenal has a specific purpose. So canalith repositioning helps with debris clearance, balance training helps with postural retraining, postrography games helps with biofeedback-driven stability. We have virtual reality, which helps with immersive gaze stabilization and desensitization. We have optokinetic training, which helps with visual motion tolerance. Rotary chair training, which helps with velocity storage recalibration. We have vestibular vibrator therapy, which helps with improving postural awareness and neck proprioception. And we have driving simulator for environment-specific confidence restoration. So each tool is chosen deliberately according to the deficit presented by the patient. Okay. So now, with that framework in mind, today we will be discussing real clinical cases from Taravishi Vertigo and Balance Center, showing how detailed vestibular evaluation directly guided our rehabilitation strategies and shaped our outcomes. So with that, we will go into our first case. So here is a 52-year-old gentleman who presented with a history of severe vertigo with vomiting approximately 1 month prior, lasting for 4 to 5 days. This was very much in keeping with an acute vestibular event. Following that initial episode, he was left with persistent imbalance and motion sensitivity, which brought him to now. When we performed the video head impulse testing, it pointed us towards complete left unilateral vestibulopathy with coexisting right posterior canal hypofunction. And you can also see the absence of any corrective saccades, especially in the bilateral posterior canals and the left anterior canals. And you can see the left lateral canal has zero gain with dispersed saccades. So now the treatment strategy here, we focused on 6 pillars. First, gaze stabilization and vestibular adaptation exercises to drive central compensation for the lost left-sided input. Then dynamic gait and vestibulospinal training to address the postural instability and rebuilding confidence in functional movement. Sensory reweighing therapy, so that we retrain the brain to appropriately prioritize visual and somatosensory inputs in absence of reliable vestibular signals. Then comes the visual motion desensitization, directly targeting the motion sensitivity and visual vertigo this patient was experiencing in busy environments. Habituation exercises for persistent motion sensitivity using graded repeated exposure to provocative movements. And finally, counseling regarding compensation, expectations, and recovery pacing. Because with a complete unilateral loss, setting realistic timelines and managing expectations is just as important as the exercise themselves. So together, these 6 components form a holistic rehabilitation program tailored to this patient. So here you will be able to see the treatment strategy that we just discussed brought to life in our clinic. So you can see the patient on a rocker board with arms crossed. Okay, the arms are crossed to reduce arm compensation. Then we have the patient standing on the balance foam with eyes closed. This is like a progression to softer unstable surface, assessing postural sway control. Then we have single leg stand with finger tracking, which also integrates vestibulo-ocular and proprioceptive systems. We have the VR headset, which helps with controlled vestibular stimulation and gaze stabilization exercises. We have vestibulospinal habituation exercise, which also helps targeting the exact plane of movement impaired. And then we also have dynamic gait exercises. Then we also have VNG-based rehabilitation exercises. And then we have functional reach to floor exercise to improve lower limb stability and vestibulo-proprioceptive integration during functional movements. Rotary chair-based rehab for improving the hypofunction and low gains. Optokinetic stimulation to retrain the vestibulo-ocular reflex. And here you can see the optic flow or spiral desensitization, where I'm holding the pattern close to the patient's face, which progressively desensitizes the visual motion sensitivity and vertigo triggers. And also stepper with focus on a target in front, used to enhance dynamic postural control and vestibular ocular stability during movement. And throughout these dynamic tasks, you can see that he's very him, but he's still safe to do those exercises. Okay, so now this slide shows us something quite elegant, objective evidence of vestibular compensation captured through ocular motor testing. So in this first video, which I'll play now, okay, this is when he came to us on the first day. Okay, so when he's taken to the right side, you can see the right beating nystagmus, but absence of left beat on left yaw. Okay, and then we did the roll, head roll. So you can see when he's taken to the right roll, there is torsional component, but on the left roll, the torsional component is absent. Okay, so after about 10 physiotherapy sessions, 10 to 15 physiotherapy sessions with this patient, the video on the right, I'll just play that now. Okay, you can see that the left beat has come now. It has started appearing here. And even the roll, the torsional component on the left roll has started appearing now. So the brain has begun reweighing and recalibrating its response to the left-sided vestibular input. Okay, so here is the objective V-hit comparison. The first V-hit chart is the one that I showed you before. Okay, and this is after about 10 sessions of VRT. So you can see that the right posterior canal, the gain remained low, but crucially, the overt corrective saccades have now appeared where there were none. So you can see this is the first V hit that I showed you before as well. And this is after 10 sessions of VRT. So in the right posterior canal, the gain remained low. There was not substantial increase in gain, but the overt saccade started appearing like here, which was completely absent before. Okay, the left anterior canal, there was improvement of gain from 0.54 to 0.63 with again appearance of corrective saccades, which were absent before. You can see, and they have become more gathered. The left lateral canal are most severely affected, remained at near zero. The gain was not that enhanced, but what changed is significant because you can see that the covert saccade latency has reduced from 130 millisecond to 100 millisecond, and the saccades have become more gathered and organized here after the VRT sessions. Okay, and finally the left posterior canal, you see improvement in gain from 0.26 to 0.36 with appearance of both covert and overt saccades, which were again missing before. Okay, so the gain numbers may still be low, but the emergence of corrective saccades across multiple canals and the improved saccade organization in the left lateral canal are hallmarks of active central compensation. Okay, another pillar of objective evidence comes from posturography. Even before we get to the challenging conditions, look at the stable surface with eyes open at baseline. The sway was more. You can also see the ellipse area for each in the top left corner. Okay, and after 10 sessions of VRT, when we rechecked, you can see that the postural sway has reduced, and you can see the ellipse area has also reduced. So there is reduced postural sway at every level of sensory challenge. And this is the outcome. Quite frankly, these numbers are remarkable because his dizziness handicap inventory score was 68 when he came to us first. And then after rehab, the score dropped to 10, 58-point reduction here. There is 49-point reduction in the triple PD score, which was 53, and it dropped to just 4 after the rehab. The PHQ-9 showed a 16-point reduction from 20 to just 4. G87, it came down from 19 to 13, so 6-point reduction. And a visual vertigo score from 83 on 90 to 7 on 90. That is a 76-point reduction. So this patient showed marked clinically meaningful improvement. So the key learning points for this is delayed rehab means delayed compensation. So the earlier you start the intervention, it's better. Movement avoidance perpetuates the dizziness. The brain needs sensory conflict to recalibrate. So we need to keep patients moving. And finally, vestibular testing doesn't just diagnose, it directs our rehabilitation. And the results speak for themselves. On to our next case. So case 2 is a 20-year-old female with a 1-year history of persistent imbalance, symptoms worsened by upright posture, movement and complex visual environments like busy or crowded spaces with significant impact on a quality of life. So when we look at the Barony Society criteria for triple PD, this patient is a textbook fit. So the diagnosis for this patient was triple PD. Now, this is a finding I find particularly fascinating and one that catches many clinicians off guard. We start with what we expect in a normal individual seen on the right here. A normal vestibular system allows for natural fluid mobility. We as individuals, we have a natural body sway. Okay, the body moves freely and adapts dynamically to its environment. But here is the counterintuitive finding in triple PD patients. In an attempt to manage their chronic dizziness and instability, these patients unconsciously adopt a rigid, high stability postural strategy, stiffening their body to feel safer. And then when you look at their posturography, the one on the left, if you see the one on the left, this is the posturography graph of this particular patient, this patient that we are discussing. This shows reduced body sway in posturography compared to the one on the right. And it almost appears better than normal on first glance. But this is not a sign of healthy vestibular system. It is a compensatory rigidity. The brain has traded mobility for perceived safety, and in doing so has locked this patient in this cycle of dizziness. So our job as vestibular rehabilitation therapists is to break that rigidity, to shift this patient back from pathological stability toward natural functional mobility. We need to retrain the brain that movement is safe and that body can sway and self-correct. So here is our triple PD specific rehabilitation program. We do visual motion exposure, deliberately confronting the patient with visual stimuli that provoke their symptoms in a graded and controlled manner. We do habituation exercises which help with repeated exposure to provocative movements so the brain progressively learns to adapt and dampen its exaggerated responses. We also do postural control retraining, specifically targeting that rigidity we just discussed, encouraging natural sway and rebuilding confidence in movement. And something quite unique, compassionate body scan, a mindfulness-based approach helping the patient develop a non-threatening awareness of their body sensations, breaking the fear avoidance pattern seen in triple PD. And this is the outcome for this patient. And this is just after 5 sessions of vestibular rehabilitation therapy. You can see that the DHI is down by 28 points. The triple PD score is down by 20 points. The depression is nearly abolished with a 10-point reduction. And anxiety is down by 8 points. And the Viva score has become half, like 33-point reduction from 70 to 37. So this patient has also shown significant improvement across every domain in just 5 sessions of targeted triple PD focused rehabilitation. So 4 quick takeaways. Reduced sway does not always mean better balance. In triple PD, it can mean pathological rigidity. And the problem here isn't how they balance, it's how the brain perceives balance. And hypervigilance amplifies normal motion signals. We are treating a central misperception. And believe your patient, symptoms can outweigh objective findings. On to the next case. Case 3 was a 39-year-old male whose dizziness was exclusively triggered by driving, specifically on multi-lane roads, bends, turns, and speeds above 80 kilometers per hour. When we heard this history, the diagnosis was immediately clear. This was a presentation of motorist vestibular disorientation syndrome, or MVDS, which is a functional vestibular disorder triggered by visually complex driving environments. The impact was significant. He had reduced driving confidence, restricted daily commuting, heightened anxiety and hyper-awareness behind the wheel, all worsened by visual complexity in traffic. So our rehabilitation approach was tailored to the trigger. We had driving simulation-based rehabilitation combined with visual motion desensitization and optokinetic and sensory integration training and graded confidence restoration during navigation tasks. So the outcomes here were reduced driving-related dizziness and spatial disorientation. This translated directly into better confidence during driving and navigation. The key learning points here are targeted driving simulation can retrain motion and visual tolerance in MVDS. And fundamentally, rehabilitation shifts the brain from threat perception to normal motion adaptation. Then moving on to case 4, a 36-year-old female presented with persistent internal swaying of floating, side-to-side swaying movement from 1 year after a history of cruise journey, and she characteristically feels better with passive motion in car. And that detail alone pointed us straight to the diagnosis of Malde-Debarkman syndrome. So the functional impact here was increased visual dependence and sensory hypersensitivity, reduced balance confidence and movement tolerance, limiting her community mobility and difficulty in visually busy environments. So our rehabilitation approach, we approach it with 2 pillars: optokinetic stimulation, targeting the velocity storage recalibration and motion maladaptation retraining. And we combine it with sensory integration and visual motion desensitization with functional habituation and progressive balance confidence training. Assessment was structured in steps. Identify the dominant motion pattern, whether rocking, swaying, or bobbing. So here we identified the dominant motion pattern as swaying or side-to-side motion in this case. We performed the Fukuda or Unterberger test, and then we used those results to guide the direction of optokinetic stimulus, making the rehabilitation truly individualized. Now, here is the outcome for this particular patient. So you can see meaningful improvement across all measures again. There is the DHI is down 14 points, triple PD score is down 10 points, depression, anxiety both reduced by 5 points, and visual vertigo is down 15 points. So the key learning points here are direction-specific optokinetic stimulation can recalibrate a brain that has become stuck in motion. MDDS is a disorder of abnormal motion perception, not true balance loss. And patients often feel temporarily better during passive motion and worse after motion stops. That is a very important clinical clue that unlocks the diagnosis for these patients. Now, finally, what do all 4 cases collectively teach us? First, vestibular disorders are dynamic. They rarely fit neatly into textbook descriptions. Detailed vestibular testing and serial reassessments are critical because the diagnosis or objective symptoms you see on day 1 may not be the same on day 10. Persistent symptoms deserve deeper thinking and may reflect maladaptive sensory processing, delayed vestibular compensation, functional neurovestibular disorders. Objective findings and subjective disability do not always correlate. So trust your patient's symptoms, not just the numbers. Rehabilitation must be individualized, tailored to symptom behavior, sensory dependence, compensation status, and functional limitations. And perhaps most importantly, successful vestibular rehabilitation is as much about restoring movement confidence as it is about restoring balance itself. And on that note, to our audience, our colleagues, and everyone who has joined us today, thank you. We hope these 4 cases have been as thought-provoking for you as they have been clinically rewarding to us. Thank you once again.
Yeah, thank you very much, Dr. Sheetal, for that excellent case-based presentation. And the cases demonstrated how useful vestibular rehabilitation is when it is linked to not only diagnosis but patient-specific requirements, impairments, and measurable outcomes. So thank you once again for sharing these practical clinical experience. Now we will move to question answer session. I request the participants to kindly post their questions in the chat box, and you can mention the name of the speaker specifically. And yeah, we have had two excellent and amazing talks today. And Dr. Helena has given us a broad and practical approach of vestibular rehab as well as approach to complex PPPV. And Dr. Sheetal has shown case-based rehabilitation. So now I invite questions from the audience. Let me have a look at the questions. Now the first question, yeah, 1 minute. Okay, just a minute. Yeah, first question I'll ask to Dr. Helena. Uh, what kind of neck issues do you look for, and what do you do for them when vestibular rehab is not working?
Really good question. So this will take us back to our training. At least as a physiotherapist, I was trained how to assess the neck, range of motion. How far can we turn left and right, flexion, extension, side bending, and what we call upper cervical mobility specifically, where you limit the lower cervical spine by flexing the neck quite a bit, and then checking rotation in particular there. And so we look at those different ranges of motion because I can tell you that whether you have someone with BPPV or someone with vestibular apathy, hypofunction, however you like to say, or a brain issue, neck movement and head movement will probably be a part of your care, ideally, if they have any mobility. Now, some people are limited because of a surgery or something, and then you have to get a little creative with body movement or whatever you can. But ideally, you will restore as normal range of motion. And there are parameters for that, are considered normal ranges, like rotation. We want at least 65 degrees bilaterally, things like that. So we will try to restore normal range of motion because that has been shown to improve outcomes in these different types of rehabilitation strategies. And then I will also look at strength. So for example, the deep neck flexors live right kind of under here. And when the person's lying on their back and they tuck their chin and barely lift their head up against gravity, avoid trying to kick in these kind of larger neck muscles like the sternocleidomastoid. You want to be able to tuck and hold. Normal is roughly 30 seconds to be able to hold without having the head just kind of flop back or kind of using these other muscles. And so if I see the deep neck flexors are not strong, that's something that I might want to work on. Also, if they really are just, again, really kind of like they might have the motion, but just when they move, they just kind of don't want to move their head. I can even use a little manual therapy to kind of goes with the relaxation or kind of that centering or grounding. And sometimes I find manual therapy to be a nice tool in the toolbox as well. So we're using our treatment should be based off of our findings. And they might have issues with the shoulders because the neck and the shoulders are neighbors. So I do try to kind of take a big picture of normal range of motion, strength, any other issues like numbness in an arm or something that may come from the neck, anything that might also need treatment that could be a piece of the puzzle to why the person is not successful in vestibular rehabilitation, because then we can do better with these vestibular rehab exercises and they have less stress because they have less neck pain or whatever it is. So there's even ways to use a laser on the head with a target on the wall to see if the neck knows where it is in space. It's called joint position error testing. So there's specialized assessment for that. And then there's treatment that you can do that kind of works on that. And then get that sensory integration in the neck and the vestibular system and the eyes and the somatosensory all work as a team. Does everybody know where they are, or are we kind of disagreeing and trying to get kind of a way to get the brain to integrate that information better by giving it these inputs like a visual input from the laser. So I hope that's not too much. All right.
No, one related question I would like to ask you, because the last webinar we had was on cervicogenic dizziness, and my question
Yeah.
to you is it the vestibular disorders which lead to the neck pain or stiffness, or vice versa? Which one you see more common, and what is your take on that?
Yeah, chicken and egg. So I would say the majority of the time, there are some vestibular issue that has led to neck limitations. So vestibular migraine, people often get neck pain as like a hint that their migraine's coming. So they think they have neck problem, but really it's the migraine talking. Does that mean that they don't start to develop, limitations in the neck? Because again, most people who feel dizzy, regardless of their cause, kind of get a sense if motion is a trigger. And so they tend to self-limit, not necessarily consciously, but subconsciously, they're starting to limit their motion. And then it's going to create impairments in range of motion and strength and things like that. So it's kind of builds together. Now, do I think that neck problems can cause an off balance feeling? I do. So if you want to call that cervical dizziness, you can. But I think it's just a case of, again, that if the sensory systems are not working as a team, including the sensory system in the neck, the patient probably won't feel right and they might feel kind of off. And that's like a term I hear a lot, this kind of vague, things aren't quite right, and I don't quite feel steady, and I don't quite feel safe, and I just can't quite pin a pin in it.
Yeah. Yeah, that's true. Now, the next question is to Dr. Sheetal. How much time period is needed so that the VOR gain in unilateral or bilateral vestibulopathy returning from red zone to green zone?
So here it's like it covers a very long the rehabilitation phase, and we cannot be very accurate by saying that it will happen in these many sessions or within this period, because every patient is different. So in our clinical practice, we have seen a patient who had low gain in all 6 canals convert to green in 4 sessions, but there is a patient who had impairment in 4 canals who still has the same impairment after undergoing rehabilitation for like 10 sessions, 15 sessions, you can say like 2 months or something. So there is no particular number for this. Every patient is different, so you have to treat it as per the case. And yes, serial reassessment is important so that we know that we are going in the right direction. And then we can plan the treatment accordingly. Yeah.
Yeah. Yeah, and to a large extent, VHIT can help us in giving this, but the functional recovery may,
Yes.
maybe earlier as compared to the VHIT
We hit. Yes.
improvements, and yeah, yeah. Then,
Yes.
Dr. Rohit has asked a question to Dr. Helena. What is your protocol for acute vestibular syndrome after central causes are ruled out uh, to rehabilitate, like from in the initial days, and how you go ahead with rehab?
Great question. Yeah, so I'm going to go back to my 2-unit role first. I'm very symptom driven when it comes to exercises. So the clinical practice guidelines suggest, for example, for acute, that you should be aiming for 12 minutes a day, which can be spread out as needed, which is both for symptom tolerance. I feel dizzy when I do this activity, but also neck tolerance, frankly. I've had quite a few patients. I know I'm talking about the neck a lot, but you can't separate, right? So sometimes patients don't tolerate a bunch of a fast head movement in the beginning. So I will ask them to start in clinic the first day when I'm assessing, to give them their first homework. I say, okay, we're going to shake our head no, because this is what we say when we say no in the US. We say side to side, or you could just say side to side, I guess, same thing, as long as you can get them to understand what you want to happen. We do this side to side motion, and it's going to be small, and I demonstrate it. And then we might start out for just a minute. And we do it for a minute. We try to kind of modulate the speed. I explain the target shouldn't be blurry, and they try it. And then I say, let me know how you're feeling as you go. And I explain the 2-unit rule. If your dizziness right now is at a 2, I don't want more than a 4. Let me know how you're doing. So they stop. They say, yeah, it's like a 3. It went up a little bit. I'm okay. Okay, great. So then we'll kind of talk about how, if it's going to be a while, depending on the patient, it can't all come as soon as I'd like. I explain how to progress themselves, or hopefully I see you, next week or in a few days, and we can see how you're doing, and then we can increase the amount of time. And so we build up to that 12 minutes a day. Now, if they do 2 minutes straight of no and 2 minutes of straight of yes, and they're like, I felt like a little bit dizzy and it went away within a minute, great. Then I do 4 minutes in the beginning of the day, or sometime before after they wake up. 4 minutes in the middle of the day, 4 minutes at the end of the day. That's 2 minutes of yeses, up, down, and 2 minutes of the side to side. And that'll make our 12 minutes. So that's the ideal, but we might have to build up the speed and the amount of time to the 12 minutes over the course of like a couple of weeks, depending on the individual. And I find that patients who have other issues, like say a past history of migraine of any kind, you usually have to go more slowly to build up those patients than a patient who's coming in without as many other issues.
By the way, on a lighter note, in the US, the pitch is yes, and you are no. But
Am
in
I the
India,
opposite? Is that the
role
opposite?
This also yes.
The
in
role.
India, the role is also yes.
Yes.
Yeah,
Okay.
that
Yeah.
is an additional. Yeah. Yeah, now, yeah, are there any questions? Yes. Now the question is to Dr. Sheetal. Can you explain in detail how you use optokinetic direction? She has spelled it optimistic, but yes, optokinetic is an optimistic rehabilitation. Yeah, you can tell about which direction you choose.
So as I discussed before in the presentation, so we first listen to the patient. So if the patient is feeling like a swaying sensation, like we discussed for the patient in our presentation, she was having side to side movement. And then we do the Unterberger test to see where the patient is pivoting to. And then that informs us on the direction of the optokinetic stimulation that we need to give. So yeah, so it is a evolving field actually. It's not something which is written in black, like it is not something where there is a hard evidence, but with optokinetic stimulation, you have to be very careful because if you overstimulate the patients, it can worsen their symptoms and it can take them back. So you have to be very careful. Start with smaller doses and slowly increase as per like the patient will guide you, like depending on their symptoms every day. Then you have to listen to that and then, increase the symptom duration, sorry, the session duration for the optokinetic stimulation.
Okay. Now, Dr. Rohiwal sir has added a comment that yes, he has also seen many times that the gain is low, but the patient has functional recovery. Yeah, that's true. That's a very nice observation that most of us we see. Now, I have few questions for Dr. Helena. Like, how, do you use in your practice of vestibular rehabilitation? How you use the vestibular vibrator, optokinetic training, and rotary chair, which are the clinical indications, and how do you incorporate in rehab?
Yes, so of course, not all of my patients get a full testing, I must say. There are unfortunately some barriers here, at least, to access. So sometimes there's only a couple clinics that do testing, and it can be months waiting for your turn. And then there are insurance or payment limitations here. So some patients it's not possible to get the testing. So for those who do get the testing, then I can use that information, at least initially, to understand objectively, of course, what we're dealing with, what kind of loss is there on the rotary chair or whatnot, looking for things like bilateral loss, usually on the rotary chair, for example, and any abnormalities on the central testing, so that's saccade, smooth pursuit, those things might be done objectively with VNG. Ultimately, I think what I care about the most, I will say, is a patient report, because there's not always correlation as much as I would expect. There's some correlation. So if someone has a significant bilateral loss, their balance is probably going to be terrible when they close their eyes, for example. So I expect that I'm going to need to work a lot on balance. And if they move their head quickly, they're probably going to lose their balance. So I already kind of have some expectations for that group. But I think that the most reliable is a pure, simple condition of a unilateral vestibular loss with no other complications like migraine, then I have a pretty good expectation of how they're going to do in most cases, and how long it'll take, which is like 4 to 6 weeks, I would say, at the most, to restore pretty functional balance And you can see, of course, measurable increase in things like gain on something like a VHIT or things like that. But I will say I've had, again, I think that Dr. Naik also mentioned this, like sometimes the patient might still show deficit, but yet they're functioning very well. They've learned how to kind of utilize their strategies and their body. And again, I mentioned that emotional piece. So people have anxiety and depression. I do find, for example, it's really harder for them to like envelop those strategies because they're kind of just like, oh, I feel so dizzy. And I'm like, well, you told me you're like half as dizzy as when we started. Oh, yeah, that's true. It's like, they kind of forget the progress. So we have to remind them a lot. And that's okay. I always say I want to meet every patient where they are. And I think it's important if you're any kind of healthcare provider to recognize that when people are coming into you, they're not just coming in with their one condition that's on the diagnosis. They're coming in with like the stress of their family. They're coming in with stuff with their job or money or whatever is on their mind. The world, if there's different issues in world safety, we'll say, that all affects how the brain has resources to help with balance and to help when there's a vestibular deficit. And so I just want to acknowledge that, part of our job, I think anyone who works with these patients can recognize is education, reassurance, letting them know that, we're here for them and they're supported, and to give them really practices on kind of grounding, mindfulness, breathing, things like that I heard mentioned in our cases are invaluable, because you saw that most of the conditions we're trying to treat, we're getting the brain is helping, with the exception of BPPV, where we just put the crystals back. Everything else is helping the brain, and the brain is complicated and special and unique to every individual. So I would just say that.
Yeah, thank you. Thank you so much. So I cannot see any further questions. So thank you very
Doctor,
much, Dr. Helen. Yeah,
Doctor, I just wanted to just say that based on this, emotional factors for the patients, I just had a
yeah,
patient yesterday. She's also a patient of triple PD, and she used to suffer from MDDS, which we have treated successfully. So, yeah, so yesterday when she came for her session, I took her in, and as usual, I asked her how is she feeling that day, and she took a moment, she hesitated, and then she told me she's feeling much better. So I asked her, why did you hesitate? Like, you're feeling better, you should be happy about it, but you don't look happy about it. And then she was like, oh no, but I'm just so scared to say that, I'm feeling better. I can go ahead and tell you I'm feeling 99.99% better. That is what she told me. So I was like, yeah, so then, here this education plays a big role. Like, we have to keep talking to them. But she also told me, and on a positive note, that her balance, confidence has improved a lot. Her MDDS is nearly abolished, thank God. But her triple PD is still a factor, but that has also, gone down like leaps and bounds. So yeah, I just wanted to point that out, because yes, many of these patients have a lot of, emotional factors which play into this scenario, because they have been suffering since so long. So, to retrain that, to educate that about to the patient, to put it clearly to them, explain every step, that helps a lot. That goes a long way.
yeah, that's so true. Because like the vestibular rehabilitation can not only help for the physical component, but we
Yes.
can, take care of their emotional component with the help of this body scan, this breathing techniques. They are really helpful. And many a times we see that their bodily components start settling, but because
Yeah.
of the process they go through, for example, in case of cupulolithiasis, they undergo maneuvers, repeated maneuvers for refractory BPPV. They're actually, as a clinician, we feel very good that their bodily component is settled, that canalith, but their perceptual component kicks in, and that is very difficult to treat. So with that, I think with that note, thank you very much, Dr. Helena and Dr. Sheetal, for your excellent presentations and sharing your expertise with us. Today's session has reinforced an important message regarding vestibular rehabilitation, how useful it is. Not only, like, as a clinician, we focus mainly on medical treatment, but it is an integral part of managing vestibular disorders. And on behalf of Neuro-Otology subsection of Indian Academy of Neurology, I sincerely thank our president of Indian Academy, that is Dr. Lakshmi Narasimhan sir, Dr. U. Minakshi Sundaram sir, he's the secretary of IAN, Dr. Kothari sir, who is a founding member of Neuro-Otology subsection, Dr. Vats sir, he's a senior neurotologist and he has done a lot of work in complex PPPVs. My friend and colleague, Dr. Srinivas UM, who is a convener of Neuro-Otology subsection, for their constant support and encouragement. So I also thank all the participants for joining us today and for your continuous enthusiasm. Your response to this monthly webinar have been encouraging, and we look forward to your continued participation in future academic activities. And once again, I request the interested participants to join our neurotology subsection, where we conduct these monthly webinars. It is a growing academic community. And thank you everyone. Have a wonderful evening. Thank you.
Thank you.
Thank you.
Thank you.